This is the intervention cascade. I typically do this in a classroom with volunteers. You'll see lots of different individuals, the mom, the partner. There's a nurse, a doctor, a midwife, and an anesthesiologist, a birth support person, and sometimes you'll have the baby nurse in as well. I'm going to introduce you to some interventions that may or may not happen during a birth. This is specific to an induction. Because an induction is an opportunity for me to show a minimum amount of intervention or the maximum amount of intervention. Again, this is the worst case scenario with every single intervention that is most common, but at any point in time, the body can take over on its own and all interventions can be stopped and mom can birth her baby on her own. But we're going to go ahead and start. It's a little past mom's due date, or baby is measuring big, so they decide to go ahead and induce. Typically, I would take this string and tape it on the appropriate or near the appropriate area, but for ease, I'm just going to lay it on top of here. This is a decision that affects partner, so he's involved in that as well. So they decide that they are going to go ahead and admit to the hospital. So they head to the hospital and they get admitted. And I'm going to go ahead and put a band on. And actually, the dad usually has a band as well as the mom, especially after the baby is born, so that they're all connected. So here's a picture of the hospital room, if you're planning on birthing in the hospital, with the bed. The bed has all kinds of functions that we can show you pictures of later. But they're here at the hospital. When they arrive to the hospital, they ask the mom if it's okay if they put in an IV. Typically, an IV is easier to put in when a mom is hydrated and her veins are bigger. Some doctors won't let moms eat or drink during labor. Sometimes they'll let them have clear fluids. But either way, accessing an IV is a lot easier earlier on than later. So we're going to go ahead and just get the IV in place. We're going to lock it and not hang any fluids on it, but it's just there if we need it. So this couple came in at 5 o'clock on a Friday night, not dilated at all, but over their due date. And the doctor's chosen the method of Cytotec, which is a chemical induction. Cytotec is a pill that's inserted into the vagina, and it's used to release prostaglandins that will soften the cervix or ripen the cervix so that it can begin to dilate. So they do this generally overnight, so that Cytotec is in place overnight. They're monitoring the baby the whole time, so they have a uterine monitor to monitor the frequency of the contractions and the heart rate of the baby. So we're going to go ahead and put this monitor on mama's tummy, and dad is eagerly watching those numbers and those baby's heart rate as well. Mom does have some sporadic contractions, but they're not regular contractions. So the next morning, they decide that there's not a lot of dilation change, but the cervix is soft and ripe, so they decide to use a uterine catheter. So this is inserted into the vagina and into the cervix, not blown up, and then the doctor or the nurse slowly increases the size of the balloon to mechanically open up the cervix until it's about halfway open. And then after that, it will just fall out and the body has to take over on its own. Most of the time, if the body's ready, then it'll just fall out and the contractions will start on its own and mom will continue to dilate. But we're adding more interventions for the sake of teaching. So we're going to add Pitocin. Pitocin is also known as oxytocin, and it is the drug that is used, or the hormone that is used to cause contractions. So the Cytotec was just for softening, and the Pitocin is for contractions. So now that the uterus is contracted, we've opened up the uterus to about 4 centimeters mechanically. We're going to add another chemical called Pitocin into this IV so that we can get those contractions going. Now it's they came in around 5 o'clock the night before, 4 o'clock the night before, and now it's about 10 o'clock in the morning. They have always been accompanied by a nurse. She's been with them throughout the night and the day. Maybe a different nurse, but she's been there. And then the midwife has been in and out to check in on them, to help them make decisions and to give them the education that they need regarding all of the things that are going on at this time. You can tell that there's been a lot of decisions that they've had to make, and it's kind of very busy. So it's very beneficial if you bring in a birth support person to kind of be there to help the family along and to help them to just support both the partner and the mom. This can be a doula, a family member, or a friend. All along the way, we have been checking, the nurse has been checking that blood pressure. We're going to put that on the arm that doesn't have the IV. She's also been taking the temperature to make sure that there's no risk of infection. And we're going to put that on Mama's forehead right here. Once we start doing more interventions, and it's been quite a bit of time, we need to probably give Mom some fluids. This is a bag of lactated ringer or electrolytes, or it's a bag of normal saline, and it's just going to give Mom some energy and hydration, as well as keep the blood pressure stabilized. So we're going to hook that up to the IV over here. So Mom's been going, the contractions are coming, but they're not strong enough yet. So the doctor decides, or the midwife decides, that she's going to go ahead and break the water. This is an amniotic hook, and it's inserted into the vagina to grab hold of the amniotic sac and break the water. And after the water's broken, oftentimes those contractions lose that cushion, and gravity can be utilized a little bit more to make those contractions stronger and longer. So we're going to go ahead and break that water, and when we break the water, we're really going to check that that baby to see how baby's handling that. So we're going to watch that really close with the nurse and the midwife, and then we'll of course watch the blood pressures and take that temperature more, because it does increase the risk of infection. This is also, this is a way that we can monitor baby. It's called an internal monitor. So this was the external monitor. This is the internal monitor. And we might find that we're not getting an accurate reading with the external, and we need to have an internal for an accurate reading. We also may find that baby's heart rates are just jumping up and down all over the place, so we need to have an accurate reading. So this is inserted just underneath the skin on the baby's scalp. So we're going to go ahead and insert that, and this is a wire that comes out and it's taped to the inside of the mom's leg. Right here, this is called an intrauterine pressure catheter. This is to monitor the force of the contractions. So this monitor has been measuring the frequency, but this is going to measure the force. So if you have this internal monitor and this internal intrauterine pressure catheter, you don't need this anymore, because we're monitoring it now internally. This helps them decide if they need to turn the Pitocin up or turn the Pitocin down. They can also decide to turn the Pitocin up or down if this is reading accurately. But if the doctor or nurse or midwife feels like they need more information, this is another tool that they can use to determine how Mom and baby are doing with all the interventions involved. So now it's been about 12 to 14 hours. Mom is super tired and feeling like she needs to have a break. So we invite the anesthesiologist in to give an epidural. There are other drugs available. There are narcotics that are going to take away the edge of the pain off. But if she wants to have a local anesthetic or local anesthesia, then she's going to use an epidural or a spinal. You can look up a YouTube tutorial on how these are done. But we're going to go ahead and insert this onto her back, and here's the anesthesiologist that's going to help with that. And he's really going to be up here to monitor that blood pressure, because sometimes with epidurals, blood pressures can change a little bit, and we're going to take temperatures more frequently as well, because they can also influence that. We also have to make sure that we keep bolusing Mom, because those blood pressures do change. So we're going to watch that blood pressure really close. But Mom is able to sleep. Dad is able to sleep. The birth partner is able to sleep or go out and get some food. and build up the energy that they need for pushing. So mom wakes up. It's been about 15 hours since they came into the hospital, and they're maybe 15 to 17 hours. They're discovering that she's fully dilated and she's ready to push. So she begins to push. The anesthesiologist can adjust the epidural so that she has more urge to push. But anyway, this mom has a great urge to push, and so she hits that pubic bone and she's having a hard time getting around the pubic bone. This is a picture of forceps and a vacuum extraction. And we're going to go ahead and place that here. The reason why that's used sometimes is because when baby is coming down the birth canal, they bump up against this bone, and they have to go under the bone and then around and up to be born. And so sometimes moms just need a little bit of help to suction or forcep that head down from the pubic bone and to pull that head out. And once it's past the pubic bone, generally moms can push out on their own. So sometimes when you hear stories about moms who had to have a C-section after they were pushed for so many hours, it's usually because they had a hard time getting around that bone, or maybe baby's head was presenting in a different direction that made it harder for them to go around that bone. You can see my fist can't turn that corner if the baby's facing a different way. That's why it's so important for baby's back to be facing the right way so they can arch that neck and back around that curve. So we're going to go ahead and do the forceps or do the vacuum, which is most common now. Very rarely do we use forceps. And if you were using a midwife previously, she cannot use the forceps or the extractor or the vacuum extractor. So we're going to bring in a doctor. Perhaps you had already chosen to have a doctor. They have a limited number of attempts on how many times they can push and use this tool. If they exceed that number, then they usually will go straight to a cesarean. So this is a picture of a cesarean birth. And remember, at any point in the game, maybe we didn't ever use the Pitocin. Maybe we didn't use the Foley cath or the uterine cath. Maybe we didn't use this. This is an example of all the different scenarios, or the most common scenarios that you might see. Maybe the extraction was successful. But again, if it wasn't, then we'll have to help her out with a C-section. At any point, we can go to a C-section if baby started to show complications with the various interventions that we've previously mentioned. So here's the C-section. If all is well, baby's able to go to mom's chest or into dad's arms. But most of the time with a cesarean, they go straight to the baby warmer with the baby nurse. Sometimes with a vaginal birth, they'll go here if they need a little bit of oxygen support or suctioning, and to check their vitals. So we're going to have that baby go to the baby warmer. And then on rare occasion, baby's not able to be with mom and dad and they have to go straight to the nursery or the NICU. And so we're going to have an example here. Remember, this is all the kind of the worst case intervention domino cascade. So we're going to go ahead and start to remove things so you can see what you're left with after you have the baby. So we're done with the forceps. The C-section is complete. Baby doesn't need to be on the warmer anymore. They can be with mom and dad. We're now listening to the baby's heart rate externally because we don't need the internal anymore. This is done. That was done at 4 centimeters, so we don't need that. We're done with the monitoring here of mom. We're done with the amniotic hook and the Foley and the intrauterine pressure catheter. The anesthesiologist will come and remove the epidural, and we're going to say thank you to him for doing for doing such a great job. So these are the things that we are left with. Let's say the baby too didn't need to go to the NICU and is with mom and dad. We might be left with Pitocin. This is used generally 1 bag after every delivery to shrink the uterus down and prevent any kind of bleeding. So we're done with that. Let's say that didn't work and mom needed more. They can use Cytotec as previously used for induction. Now they can use this to actually stop postpartum hemorrhage as well. This time it's actually inserted into the anus instead of the vagina. This due date is gone and done. Now, baby's not at risk anymore. Mom is not at risk anymore. The whole family's all together. So the midwife is able, or the doctor, they're able to leave. Everything's under control. And they're able to head out. The birth support person might stick around a little bit longer, help with breastfeeding or helping contact family or getting food for you. But they usually leave around when everything's stabilized. Mom will need to maybe have a bag of fluids, depending on how her blood pressures went and how much fluid she lost and how long she was without food. So it might be for rehydration as well. So we'll just leave that bag there for a bit, but now it can go. Blood pressures are stabilized, so we don't have to take the blood pressure anymore, but they will continue to take this blood pressure after the birth for for the whole time that you're there. And then the doctor gives the okay, the nurse or the midwife gives the okay, and they decide that it's okay for you to be discharged. It's usually about 24 hours after your birth, unless you've had a C-section, it's longer, or unless you're positive of group strep B, or if there's any other complications. But if all goes well, then you can usually discharge about 24 hours to 48 hours. We're going to take that IV out because we don't need it anymore as we're getting ready for discharge. You're going to say goodbye to your nurse and everybody that helped you there. And you can keep your band, put it in your baby's book if you want, but you can go ahead and remove that as you head out. I always keep this temperature here because even after you discharge and go home with your baby, you'll still take your temperature for 72 hours to watch for infection. So again, remember, this is all the interventions that can take place. It doesn't have to be this way. It can have one or two things happen, or all or more. But this is just a general idea of the domino effect of induction interventions.